much deeper than the height of the R in V1. In right ventricular hypertrophy, you have the R lower than the S. But there are exceptions. You can have this one RVH pattern in a tall, lanky individual. A very tall, lanky, may show this kind of ECG, but he has no true RVH. So there are exceptions always. So ST segment, the normal is isoelectric. You can have ST segment elevation, acute ST elevation MI, you can have ST depression, MI also, non-ST segment. Or you can have the early repolarization pattern. After depolarization is repolarization. If it's too early, it may give us an ST elevation, usually found in V2 to V4. So early repolarization is not pathologic. Okay? It's physiologic. So ischemia and injury. With myocardial ischemia, we expect the ECG1 ST wave changes. The same with injury. Injury is a stage 10 ischemia, but more often you see ST elevation with injury. If the injury is prolonged, that can lead to infarction. So infarction means death of the myocardial tissue, necrosis. It will produce what? Q wave in the ECG. Q wave. So you have seen Q wave? The first negative defection in the ECG of the QRS complex. The QRS complex represents ventricular depolarization. Depolarization of both ventricles. So before the R, the negative depolarization is a Q wave. But not all Q waves are pathologic. It has to be wide enough, 0.04 seconds. And the depth should be at least 25% of the R amplitude. So the width of the Q wave is important. Because if it's not wide, it's not deep. It's insignificant Q wave. That's not the Q wave that results from a previous myocardial infarction. Okay? So insignificant Q waves. The pathologic Q waves are those that are wide enough, 0.04 seconds, which is 1 small square. And depending on the R wave amplitude, if the height of the R is 8, 25% is 2 mm, right? If the R is 8 mm, 25% is 2 mm, so the Q wave should be 2 mm deep. That's a pathologic Q wave. You have ST segment depression, ST elevation. In the chest, the significant elevation is 2 mm, in at least 2 what he was needs. For the limb leads 1 mm ST elevation. Infarction is Q wave. Look at that one. Look at our Q wave. It's eyeballing is obvious. It's more than 1 small square, and the depth of the Q here is about 1/4 of the R, pathologic Q wave. In contrast to the insignificant Q waves. Then when you see Q waves, it's found in V1, V2, it means there is septal infarction. In the septum, ventricular septum is the one infarcted. V3, V4 Q waves, the anterior wall of the left ventricle. Okay? And V5, V6, anterior lateral wall. 2, 3 in the inferior wall of the ventricle that rests on the diaphragm. Is there a diaphragm? The heart sits on the diaphragm. That sits on the diaphragm is the inferior wall. It's represented by 2, 3 ADF. If you have Q waves in at least 2 out of the 3, 2, 3 ADF, 2 out of the 3, you have significant Q, that signifies a prior infarction of the inferior wall of the ventricle. Okay? And 1 AVL lateral wall. Q wave, normal is upright, and inversion can be due to ischemia. If there's peaking, it could be hyperkalemia or early, very early in a patient with acute ST elevation myocardial infarction can hit as a peak T wave. It's not specific, not that if you see a peak T wave, it's automatically hyperkalemia. No. It could be early MI, it could be hyperkalemia, but it could be due to repolarization problem. It could be benign condition, non-specific changes. QT again, QT can be prolonged, can be shortened depending on what. Hypercalcemia can shorten the QT, hypocalcemia can prolong the QT. Shortened or prolonged QT can lead to ventricular arrhythmias, ventricular tachycardia, ventricular fibrillation, which can lead to sudden cardiac death. Okay? And U wave, the normal U is smaller than the T, and if it's prominent, it is what? Suggestive of hypokalemia. It can be inverted in hyperkalemia. And the arrhythmias, atrial fibrillation, I'll show you examples. So atrial fibrillation. I'll just show you atrial fibrillation. Blocks. This is what? Sinus tachycardia. You see P waves and the rate is fast. Look at V5. 300 or 50. Sinus tachycardia, more than 100. This one. And tachycardia. PEC, where's the PEC? Premature atrial contraction. Look at the lead one. The PEC is this one. This one. Premature. Is followed by compensatory pause. This one. So, anterolateral wall ischemia. Look at V4, V5, V6. In V4, you have T-wave inversion, that's obviously here. V5, V6, you have ST depression and T-wave inversion. Okay? Ischemia. What about this one? First degree in black, look at the P-wave, look at V1. By eyeballing, you'll know that's your P and then the PR segment, the normal. First degree in the normal is how many small squares? Up to 5, 3 to 5 small squares. The PR interval. If it's shorter than that, it's called a short PR. Less than 0.12. It's longer than 5 small squares. It's prolonged PR. First degree in black. Okay? So, clinical use of the heart blocks, you have to be careful with the medication you're going to give to the patient. If your patient is on beta blocker, and then you look at the ECG, the PR interval has increased, you should withhold it. Otherwise, you can push the patient from a first degree AV to a second degree AV. Okay? And they may require pacemaker. Advanced hybrid AV. This one, look at that. Where are the T waves inverted? So diffuse. Look at V2, V3, V4, V5, V6. This is the appearance of inverted deep and symmetrical T-wave inversion. inferior wall is linear. One, lead one also you have, which is lateral wall, and B2 is septal, B3, B4 anterior, B5, B6 anterior. So diffuse, almost lower. Next, this one. This is acute ST elevation infarction. Look at B5, B6. Look at the ST elevation there. MI, myocardial infarction. ST elevation. This one, atrial flutter fibrillation. This one is all obvious. Instead of seeing P waves, you see these are flutter waves. So this is flutter, atrial flutter waves. You don't see the P and the QRS, the P wave, it's flutter waves. This one, atrial flutter. Atrial flutter is very unstable rhythm, so more often we see atrial fibrillation. Very rarely can you see flutter. So at times we're lucky we can find here the above is atrial fibrillation, the below is atrial flutter. Okay? Unstable connection. So very common to see. Here, look at what you have here. Look at the T waves. Very pointed, but it is unfair to show this to the student and identify the second degree effect. For second degree effect is defined as you have two types actually, wing impact, type 1, second degree, and type 2. The wing impact type is you have the PR interval that is normal, and it lengthens and lengthens and lengthens until there's a warning, and then the QRS is dropped. The second degree AV block, Mobitz 1 or wing impact, Mobitz 1. The Mobitz 2, the PR interval is constant. It could be normal and constant. It could be prolonged and constant. And suddenly, there's no pattern. Suddenly, a QRS is missing. That second degree AV block, Mobitz 2. They just listen. You're still first years. It's enough to know that when we say second degree AV block, there are two types, Mobitz 1 and Mobitz 2. In Mobitz 1, there is gradual incremental increase in the PR interval until you have a block. The block is what? You don't see QRS. So after a P wave, a QRS is absent. It's not able to be transmitted to the ventricles. That's the Mobitz 1. The Mobitz 2 is there's no warning. Unlike the Mobitz 1 is you will see the PR lengthening. This is the PR interval 0.22, 0.26, 0.28, 0.30, and QRS absent. In the Mobitz 2, the PR is constant and suddenly the QRS is gone. This one, left ventricular hypertrophy, look at V5. Your S in V1 and R in V5 by eyeballing, it reaches more than 35. This is left ventricular hypertrophy. And look at the right atrial enlargement, look at 2-3 ABF, they have a tall peak, P waves. Look at the P wave should be rounded, and the normal morphology or form of the P wave is rounder. There's a tall and peak P waves in 2-3 ABF, which means there is right atrial hypertrophy. The left ventricular hypertrophy here is the S in V1 plus the R in V5, more than 35 cm. Look at the calibration. Don't forget, when you doing ECG, this one. This should be 10 mm. 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Should be 10. This is a normal calibration. If your technician fails to do the right calibration, they will just use 5 mm. You're actually underestimating the voltage. 5 mm right, they got it. So, or if it's 27. So, if you are going to add S in V1 plus R in V5, dapat 10 20 na siya, ang S mo is, in V1 is 40, divide by 2. Because 20. Yung 40 imong R in V5, kung 20 na siya, imo 20. So 20 plus 20 is 40. For example, 12 imong S. Yan, 12 imong 12 imong S, 12 imong R. If you add it, 24. There is no LVH. Kung normal na siya, 10 mm. Pero kung 5 ba siya, imo i-times 2. So, what siya? 48 na siya. So, there's LVH. Balihon mo, if your S is 40 and R is 40, 80 siya. But then, it's too big at 20 man, divide by 2. Maabot sa 35 LVH. O sa 35, there's no LVH. Based on the voltage criterion. This one. Right bundle branch block, look at V1, V2. You have R prime. The first R is small letter R, the second R is R prime, big letter R prime. V1, V2, your right bundle branch block. This one is what? Left bundle branch block, but not classic, Look at V6, you have a widened R, but not a natural. This is not a classic. This one, who can guess what is this one? What happened to this patient having chest pain? Look at the ST. V5, V3, V2, V4. What is this? What happened to the ST segment here? Elevated. This is ST elevation myocardial infarction. Look at V5, diba? You have your Q, then an S wave. Look at V2, so V2, V3. Look at V2, V3, V4. Okay? You have ST elevation, MI. But before you can see ST elevation, pwede ka mag-tall and peak waves. MI, myocardial infarction. This one. What is this one? Sinus bradycardia. That's the one. Inferior wall. 2-3 AVF represents the 2-3 AVF. Inferior wall of the left ventricle sits on the diaphragm. So ST elevation, myocardial infarction in the overhead